Okay, everyone. So I'm going to get started. So we have a little video. All right, so my name is Dana, which you probably already know, but just in case. And today I'm going to be presenting on medication safety. First, awareness of modified release dosage forms and drug delivery systems. So this presentation is for both pharmacists and pharmacy technicians, and it's also a medication safety CE. So as for disclosures, I have none. And then as for acknowledgements, I had two pharmacists look over this presentation. I had both John Bruno and Marie Varela, so thank you to them for looking over this. So like I said, we're gonna do this presentation for both pharmacists and pharmacy techs, so I have objectives for both. First, starting off with, we're going to be able to recall the distinct differences between modified release dosage forms and conventional dosage forms. We can then recognize the ways in which medication dosage form awareness can then decrease the risk for med errors. We're going to be able to state the abbreviations commonly used for modified release dosage forms, and then identify and review some of the drug delivery systems so that we have better understanding and recognition before we dispense. And then the technician objectives are very similar. So we're going to be able to define what a modified release dosage form is, recognize the ways in which medication dosage form awareness can play a role in decreasing med errors, memorize those abbreviations that I'm going to talk about, and then recall those drug delivery systems so we have better understanding when filling. So first I have a question. You can totally unmute yourself. You can write in the chat, but point of view, you're the technician that's manning VC2 and it's 10:03, so it's Pix's time. Your first label prints and it's for 20 Depakote. And to your dismay, the VC only has singles, so you have to count each tablet. You see that some say the drug name followed by ER and some say SR. So what do? Your options are nothing. It's the same drug, so continue to fill. B, no time to hem and haw, just pick one, bag it up, move it along. Or C, something's not right, alert the pharmacist.
C.
I don't know who's laughing because I can't see, but yes, so C is correct. All right, so now point of view, you're the pharmacist. You just got an email from John Bruno earlier that there is a shortage of IM haloperidol decanoate. An order for haloperidol LA long-acting 25 milligrams IM monthly pops up on the queue. You decide to work around the shortage by dispensing 5 ampules of short-acting haloperidol lactate, 5 milligrams per ml, to make up for that 25 milligram dose. What next? You can either congratulate yourself for the clever find and dispense to the patient for immediate administration. You can double check yourself and make sure interchangeability is possible and safe. Or you could panic, cancel everything. There's nothing we can do. The patient's not going to get the medication. It's all over. So what do we think? Is it in the chat? Let's see. Yes, so it's B. Ooh, yep. Okay. So increasingly, medications are being released as modified release dosage forms. So what is contributing to medication errors with these modified release dosage forms? And the main thing I want to point out is a knowledge deficit when it comes to the various modified release products. If we don't know what it is and we don't know how to use it, we probably shouldn't be dispensing it because we don't know how it's going to affect the patient. The problem with these medications is that it's typically the drug name and then it's the strength followed by a suffix which could be unknown, as well as the fact that the suffixes that are used have lack of uniformity and no standard interpretation. So you could have 2 different drugs that are followed by XR and they don't necessarily have the same strength, they don't necessarily have the same frequency, so it can get really confusing if you're going to use the same suffix with no standard interpretation. And then lastly, of course, drug shortages requiring substitution. So from the example before, when we get an email from John Bruno, we have to kind of scramble and figure out what are we going to use instead. And you have to make sure that the medications are interchangeable, the dose is appropriate, and the patients are getting what they should be getting. So one of the main purposes of this presentation today is to help with filling in some of the gaps regarding the modified release products in hopes that a better understanding of how they work can prevent further confusion or mix-ups between the products. So firstly, I wanted to address the knowledge-based error, which of course occur due to lack of knowledge. So the way that we can address that is by proactively educating ourselves, the pharmacy staff, about the formulations, the delivery systems, and those common suffixes. The second thing I want to address is action-based errors, which are also known as slips. And that would be such as not counting all the singles for Pyxis, or skipping the scanning function on the VC, or rushing to scud something. And so it's super important that we're mindful when we're receiving and filling orders by cross-checking, not being rushed, and carrying out tasks to completeness. On the other end, obviously, prescribers should also be mindful when they're writing these orders. So that would be having the complete drug name, writing out extended release as opposed to just writing the suffix, adding in 24 hours or 12 hours, depending on the frequency that they want to use. That would be really helpful to us and to make sure that there's no need for clarification. But if there is need for clarification, of course, the pharmacist should be calling the prescriber to make sure that the dosage form agrees with the prescribed dose. So what does it mean for a product to be a modified release dosage form? So essentially, a modified release dosage form releases the medication in a controlled manner, whether that's at a predetermined rate or duration or location. And you can see various suffixes that manufacturers use interchangeably. And those would be such as SR, CR, XR, XL, and those are just a couple. And this is in comparison to immediate release or conventional dosage form, which is short acting or short lasting, fast acting, and the medication effects peak in a small window of time. So now I have a bit of a visual to explain the differences between conventional and controlled release a little bit better. So as you see on the left-hand side, you have your conventional dosage release form. And the MTC and MEC, MTC stands for the toxic concentration and the MEC stands for the effective concentration. So every time that you get a immediate release dosage form, you're gonna see a spike in the blood level and then it comes back down. So you have these peaks and valleys, which can lead to an easier way to reach those toxic concentrations, because every time the drug runs out of the body, you have to give another dose. So conventional dosage forms typically have frequencies anywhere from 1 time a day, but it could go all the way up to 4 times a day. Whereas on the right side of the screen where you see the yellow line, controlled release products are given once, and then they pretty much plateau and they stay in a nice even spot between your effective and toxic concentrations. So you don't exactly have to worry about it randomly spiking and hitting those toxic concentrations. So there are many advantages and reasons why these formulations exist. And so as I mentioned before, obviously less fluctuation in those blood levels, which ultimately lead to less frequency in dosing and ultimately leading to more compliance in patients if they have to take it 1 time a day as opposed to 4 times a day. And due to the fact that there isn't as many peaks and valleys, that can reduce the adverse side effects. As for the last part, reduction in overall healthcare costs is more of an if then because type of statement. So if you're going to use an extended release dosage form, then it will be more expensive initially, but because it has enhanced therapeutic benefit, fewer side effects, better compliance, it ultimately ends up being a reduced healthcare costs later on. So now you know the advantages of these modified release dosage forms, but what are the disadvantages? So of course, firstly, being abbreviation unknown by staff. Secondly, being an overdose. So if a patient is given the wrong med, if it's taken too often, if it's difficult to get out of the body system just because of it being extended release. These tablets or extended release dosage forms can also be large. They can be hard to swallow. And a lot of times they can't be open, crushed, or chewed. So it's super important to double check the package inserts. There's also something called dose dumping that can occur. So because a larger dose is typically needed, It's released slowly over time, and if there's a malfunction in that technology or even a lapse in judgment, such as in that haloperidol example, this can be dangerous for a patient. And then lastly, there's a loss in flexibility. So like I said before, if a medication is opened, it can be dangerous if it's not supposed to be. If it can be chewed, you have to double check with the package insert. And especially when it comes to missing doses, some of the extended release products are only given every 3 months. So if you miss that dose, there's a very specific window of when you can take it again. So today I'm going to go through a lot of medications that our pharmacy does have, but also quite a few that our pharmacy does not have. And those are just for your information, and you can maybe learn a couple new things along the way. So starting off, most modified release products are orally administered tablets and capsules. However, some of the other modified release dosage forms that I'm going to touch upon today, as well as drug delivery systems, are ocular, parenteral, subdermal, vaginal, as well as subgingival. So I wanted to give you some background as to why certain drugs come in modified release forms. So can every drug be extended release? The answer is no. Not all drugs are suited for formulation into extended release products, and not all medical conditions require treatment with such a product. So firstly, medications that have slow rates of absorption are inherently long-acting. So if they're already going to be in the system for a long period of time, you don't necessarily need to create them into an extended release product. Additionally, drugs that are excreted from the body too quickly would need very large quantities to become extended release products, and that can be really dangerous to the body and to the patient. Also, if we're not sure how well the drug is absorbed by our body, we should likely not convert it into an extended release product, because we won't know how it responds in the body that way either, and then it'll be more difficult to take it out of our body system. As I mentioned before, there's not much flexibility when it comes to these extended release products. And then to harp on the same point, incredibly large doses to sustain therapeutic blood levels can be unsafe, so we want to try and avoid that so the medication has a good margin of safety. And then lastly, acute conditions may require dose adjustments and would likely not benefit from extended release formulations. Extended release formulations are best for patients that are stable and can handle the medication in their system without manipulation, whereas someone with an acute condition, for example, like pneumonia, who may not be stable, which obviously wouldn't be getting an extended release product, from their day-to-day changes. You're gonna need to change the dosage, change the frequency, their kidney function. You have to make sure that they're stable before you're giving them a medication that will last in their system for a while. So I have some participation questions. Also feel free to write it in the chat. What are some typical oral modified release formulation abbreviations we see in the pharmacy? ER, Also ER, CR, yep. IR, yep. Perfect. Okay, so although I'm not doing a study on our pharmacy staff, and I do not have a baseline gauge of where we are at regarding knowledge of modified release dosage forms, previous studies have been done due to reports of confusion in the suffix usage and between short and long-acting medications. So this was a very small 2-week study, including registered nurses, licensed practical nurses, and student nurses from 2 urban acute care hospitals in Alberta, Canada. And essentially what happened in this study was it's broken down into 2 phases. So the first phase was asking the nursing staff to define 4 abbreviations. They were shown CR, SR, ER, and IR. And then in the second phase, the nurses were asked if it would be appropriate to administer a certain medication in a picture. So there were 3 different presentations of Oxy-CR label with a patient order for Oxy-IR. And in each of the pictures, they used the words short and long to help the nurses define the whether each medication was short acting or long acting, and some had short, some had long, and you'll see in the results what that means. And essentially the objective of this was to evaluate the comprehension rates for abbreviation used to denote the short and long acting medications and to reduce potential errors in selecting these medications. So as for the results, As you can see from phase 1, about a quarter of the nurses knew all 4 abbreviations, and slightly more were able to classify it as short or long acting. Now for the phase 2 data, it proved that it was helpful when the words short and long were used in combination with the pictures and the order shown. And essentially the conclusion of this study was that abbreviations are problematic. Many of the nurses had thought that ER actually meant emergency release instead of extended release. And overall, an effort does need to be made to clarify the communication of different release rates. So these are the suffixes that we see most commonly. It's the drug name, typically followed by one of these. And although these terms are often used interchangeably by the manufacturer, individual products bearing these descriptions may differ in their design and performance. So we have sustained release, sustained action, prolonged action, controlled release, extended release, timed release, and long acting. So quite a few. So the FDA actually only defines modified release dosage forms in 2 definitions, which are at the top. So first being extended release and the second being delayed release. And extended release essentially just means it allows a reduction in dosing frequency from that necessitated by a conventional dosage form. And the example for that would be metoprolol succinate and tramadol ER. For delayed release, these are medications, they are designed to release the drug at a time other than promptly after administration. So it typically means that the medication is coated in something so that it remains intact, which reduces gastric distress. So you would have something like enteric-coated aspirin. And enteric-coated is a barrier to prevent the gastric acids in the stomach from dissolving or degrading the drug. There's also something called repeat action, and that's usually a medication that contains 2 single doses, kind of stacked one on top of the other. It looks like 2 tablets smushed together, and the one would be for immediate release, and the second would be for delayed release. And the example for that would be dexchlorpheniramine, which is an antihistamine. And then lastly, we have targeted release. So the drug release is directed towards a specific body region or tissue. And we would want that for a reason such as cancer medications, because we would want it to target the tumor as opposed to the entire body. So I'm going to go through several oral dosage form technologies. They're mostly FYI, and I'm just going to keep them as simple as possible just so you're aware of all of them. So first we have coated beads, granules, and microspheres. And these coated beads provide different desired rates of sustained or extended release, and they can target desired segments of the GI tract. And the example for this would be Adderall XR. Then we have a multi-tablet system, which I think is really pretty. I like that it has the pretty colors. But anyway, so each capsule contains mini tablets. Some are uncoated for immediate release. So that would be like your white ones. And then the others are coded for extended release. So for example, the yellow ones in the picture. An example for this would be theophylline comes as a multi-tablet system. Then we have a microencapsulated drug. So solid liquids or gases enclosed in thin wall materials. And you can manipulate the rates of drug release by changing the wall to drug ratio, the coating, and the film on the material. And the example for this would be micro K. And one of the advantages of microencapsulation is that the administered dose of a drug is subdivided into smaller units that are spread over a large area of the gastrointestinal tract, which may enhance absorption by diminishing the local drug concentration because it's spread over a greater area. Then we have embedding the drug in a hydrophilic matrix system. So the way this works is the capsule is ingested, water is going to penetrate it, the outer layer forms a gelatinous plug, and then the drug diffuses gradually as that plug dissolves. So an example for that would be tolcapone. Then we have ion exchange resins, which is manipulating the chemical makeup of the drug to be released based on acidity. So the stomach is obviously more acidic than the small intestine, so you can target that. And for example, would be a phentermine resin capsules as well as hydrocodone polystyrene. And then lastly, we have the osmotic pump, which I feel like is the most common. But the way this works is that the tablet is swallowed. A thin barrier permits water to enter the core from the patient's stomach. The drug dissolves, the pressure increases, and then at the very top where there's the delivery orifice, the drug gets pumped out. And so, for example, I have Flucontrol XL, Procardia, Tegretol, Cardura, Isradipine CR, so lots of examples of osmotic pumps. So lots of medications with the same active ingredient can come in a variety of modified release forms. And of course, this can cause a lot of confusion and higher chance for med errors. So I just want to go through a couple interesting examples that you'll likely come across. So starting off with memantine, this is an interesting example since the way that it works from going from immediate release to extended release is not by basing it on the total daily dose and then adjusting frequency. Essentially, the total daily dose gets thrown out the window for memantine. So when you're converting from immediate release to extended release, the immediate release dose would be 10 milligrams per day, and the extended release dose would actually be 14 milligrams per day, which is sort of interesting because you're technically getting more drug that way. And then as well as if the patient's getting 20 milligrams per day, the extended release dose would be 28 milligrams per day. So the next example is valproic acid, which as you can see comes in many formulations. So we have the Stivalproex delayed release sprinkles, as well as the delayed release tablets, as well as the extended release tablets. And these different formulations are not AB rated. And what that means is the FDA has something called an Orange Book where they list all of the medications that are therapeutically equivalent. And if they are, they get an AB rating. But these medications are not AB rated, deeming them not therapeutically equivalent, meaning that they are not interchangeable. So, however, in the hospital, if it is absolutely imperative to switch from one to another, there are dosing guidelines on how to handle the switch. But in technical terms, if you're considering it by FDA standards, they're not interchangeable. And additionally, from talking earlier, our hospital has been out of valproic IV for quite a while. So as for converting IV valproic, the closest interchangeable option is actually the oral solution. So the next is bupropion, and all of these medications contain the active ingredient known as bupropion. The picture furthest to your left is Wellbutrin SR, and besides having sustained release, it is also used for smoking cessation, while the other formulations are not. It has a 12-hour release, resulting in twice daily dosing. And then the two pictures on the right show the same medication of bupropion XL or XR, which is typically prescribed to treat depression. And these have 24-hour release and are given once daily. So in Power Chart, when there's an order for bupropion, it actually says XL and then it says 24 hours right after. So that's really helpful for both doctors and pharmacists when ordering and verifying to know that it's once daily dosing. And if you see twice daily, you should be second guessing. So this is just another visual which should remind you of the charts that I showed you earlier in the presentation. So these demonstrate the blood levels when using each formulation of bupropion. So SR and XR products are not therapeutically equivalent or interchangeable. So if a patient has a home med that's SR and a doctor puts in an order for XL or XR, it should raise suspicion of keeping the patient on what they started on. However, once again, if it's absolutely imperative to switch from one to another, there are dosing guidelines on the package insert. And essentially what you do is you just keep the total daily dose and you can separate it based on frequency. So obviously SR being BID since it's 12-hour, and then the bupropion XL being daily. So then we have tacrolimus, and these are essentially used for the prevention of organ rejection in transplant recipients, typically in combination with other immunosuppressants. So tacrolimus ER products are not interchangeable, and if they're substituted, serious adverse effects, including graft rejection, can occur. So each of these products actually have different pharmacokinetic properties. However, it is possible to switch from Prograf to Astograph XL because they are actually 1-to-1. And then Prograf to Invarsus is a bit more complicated since the ratio is actually 0.7-to-1. So it does require a bit of math to switch that one over. And we do not convert from Astograph to Invarsus. I spoke with Alex earlier today, and she told me that if a patient is typically started on one of the extended release medications, we typically just leave them on it. We don't really convert them to one or the other. So this is straight from the Invarsus package insert. And this graph shows blood levels of medication over several hours. And then the orange line is your Invarsus. And then your dotted line is showing your Prograf and your Astograph XL. So although it's not extremely drastic, both the Prograf and Astograph XL do have a peak when it's first given, administered. And the Invarsus is more of a steady plateau. And additionally, some of the things that were pointed out about the pharmacokinetic properties of Invarsus was that it has 50% greater bioavailability than the other formulations. It obviously has that reduction in the peak since it's more of a plateau. And it also says that 20% lower doses achieves comparable under the curve and trough levels. So the main takeaways from these oral modified release dosage forms is that they're not interchangeable. So if a pharmacist is unsure, it's important that they find reliable resources to find the answers. And for technicians, it's important that they're aware of the differences and escalate to a pharmacist to help with the substitutions. Also, many modified release dosage forms cannot be crushed or chewed because it can compromise the drug release features. It can cause serious side effects. It can prevent the med from working properly. It could alter how the body processes and responds to the drug. Lastly, the last bullet is mostly FYI. So sometimes the non-erodible plastic matrix shells and osmotic tablets remain intact in the GI tract after they're taken, and the empty shells are known as ghosts, and they can be seen in the stool. But it's actually very normal for that to happen, and drug absorption has taken place. So if there's ever a patient that claims that it went right through them, the medication was absorbed and it did what it needed to do. So one last participation. What are some typical injectable modified release formulations that we see in the pharmacy? Abilify, yep. So definitely a lot of the antipsychotics. Haldol, yep. Yep, Ozempic, okay. Okay, so now we're gonna move on to long-acting parenteral systems. And the difficult part about modified release parenteral formulations is that they don't have the abbreviated suffix after them, such as the oral modified release dosage forms did. So these have to be recognized by name, that they're either immediate acting or long acting. Okay, so this slide is very colorful and extremely chaotic, but it's really just to demonstrate that there are so many technologies for long acting injectable therapies with a common goal of either slow and controlled release or delayed clearance or resistance to enzymes or increased stability. So there's just a few that I'm gonna point out. Okay, so the top box shows the chemical modification of a drug by manipulating their attachments and linkages within the structure. So an example of this would be liraglutide, which is actually achieved by lipidation. So they tack on a lipid to create it and make it more long acting. For the next one, I just thought this one was really cool. So they actually can attach tiny nanoparticles or nanomedicines to our red blood cells, and they're called RBC hitchhiking. So they last in our circulation longer. And then lastly, for nanoparticle technology, it includes many of our long-acting antipsychotics. So tiny little drug particles are dispersed throughout the injectable formulation, and solubility is typically manipulated here. So many of the antipsychotic medications that we carry in our pharmacy are those nanoparticle technologies that I just spoke about. But the danger with these antipsychotics is that they have very similar names with slightly adjusted second names to help distinguish between the different frequencies of administration. So it's super important to double check that the right med is ordered and dispensed. And so basically what you're looking at on this slide is the colors correlate with the medication. So for Invega Trinza and Invega Sustaina, they both contain paliperidone. However, one is given every 3 months and one is given every 1 month. And the same for aripiprazole, it comes in Aristata and Maintaina, and one is given every 2 months and one is given every 1 month. So next we have implant systems, and implants are long-acting dosage forms that provide continuous release of a drug, often for periods of months to even years. And they can be in the form of pellets. They can also be gel, solid, metal, or plastic implants, or they can be drug-eluting stents, which are coated with or containing drug and then placed in an area that requires the effect. So I have 2 examples for this. Thankfully, on these boxes, they actually say LA, so you would know that they're long-acting now, knowing the suffixes. And so we have Zoladex or Goserelin, which is dispersed in a matrix of biodegradable implant designed for subcutaneous injection. And it has continuous release for over 28 days, but there is also a 3-month version. And then on your right-hand side in the yellow box, we have Hystrelin implant, which has a reservoir drug delivery system to continuously deliver the medication over 12 months when injected subcutaneously. So this is pretty similar to the hydrophilic oral modified release dosage form that I mentioned before. So it has that hydrophilic core or plug, and this one has a hydrogel reservoir. Then we have ophthalmic dosage forms. So actually 80% of administered ophthalmic drug is lost through blinking, tears, nasolacrimal drainage within the first 5 minutes of instillation. So extended periods of therapy can be achieved by formulations that increase that contact time of the medication and the surface of the eye. So there's 2 ways that we can do that. First, starting off with gel's extended release. So that would be like adding ingredients to increase viscosity. And viscosity is just a fancy term for being really thick and sticky. And timolol is an example of that. So timolol has an ingredient in it called gelin gum, which essentially forms a gel upon contact with the eye. The other example would be ophthalmic inserts, and that's when the drug is sandwiched between transparent rate controlling membranes. So as you can see in the picture, there's the 2 lighter blue circles on the very top and on the very bottom, and then the drug is sandwiched between. So this is an example of pilocarpine inserts, which provide a week's worth of medication as opposed to the conventional eye drops, which are actually administered 4 times a day. So it definitely takes off the burden of having to give yourself eye drops 4 times a day. So then we have intravaginal drug delivery systems, and these are used for continuous release and local absorption of the drug, and that'll help minimize the systemic toxicity and of course, eliminate that peak and valley that we saw with conventional drug delivery. So we have seen these boxes before. We know that Mirena is too big to scud. We know that Cervidil is in the freezer, but do we know what's inside the box? Do we know how the drug works? So as for Mirena, it is a T-shaped frame and the center holds the drug. And then the drug slowly migrates out of the device and it can prevent pregnancy for up to 5 years. And then we have Cervidil, which I had no idea it looked like this. I honestly thought it looked like a suppository, but so it's actually a thick, flat rectangular device, which is enclosed in a knitted pouch. And the long knitted tape is for retrieval of the device. And the way it works is when it's placed in a moist environment, the unit absorbs water, swells, and then releases the medication at a rate of about 0.3 milligrams per hour. Then we have transdermal delivery systems, and these essentially support the passage of drug substances from the surface of the skin through all of the layers and then eventually into our circulation. But it's super important to note that these are systems, meaning that they have an entire process that allows the drug to be released at a controlled rate. They may look simple and they may look like basic patches, but they are not, and they should not be confused as such. An advantage of these systems is that they provide extended therapy with a single application, which of course is going to improve compliance, lessen the burden of those multiple doses throughout the day. So we have two types of transdermal drug delivery systems, starting off with monolithic, and that just means that there is incorporated and dispersed drug into a matrix layer, which is between a backing and a frontal layer. And then we have membrane-controlled transdermal drug delivery system, which is containing a drug pouch or a reservoir with a barrier that controls its release. So the best way to avoid med errors is for us to familiarize ourselves with the extended release products that we dispense in our own pharmacy. So we have all of these medications. And as you can see in all of the red boxes, they are given and then left on the body for extended period of time. So whether it's for 3 days or 24 hours or 72 hours, it's for an extended period of time. So a patient who's getting frequent orders for these types of medications throughout the day should probably raise suspicion. So no one should be getting 4 patches in the same day to be administered. Another thing to keep in mind is these are systems, they are not patches. So they should not be cut because they can release the drug all at once and we can have that dose dumping that we want to avoid. And then lastly, we have something called subgingival sustained release, which I've never heard of before, but I thought it was cool. So I figured I would add it in this PowerPoint for completeness. We obviously don't see this on a typical basis in the hospital, but it is something that exists. So on the left in yellow, we have minocycline microspheres, and subgingival essentially means that they get placed in the gum line, and this delivers the medication over a period of time within the mouth. And then on the right, we have doxycycline, which is in something called an atrogel delivery system, which is gel-like, is placed subgingivally. It solidifies, which probably seems a little bit uncomfortable, and then it's released over 7 days. So in summary, to wrap up this whole presentation, it's really about educating ourselves about those suffixes that are used, the modified release dosage forms, the delivery systems. It's important for us to take the time to double check and count and scan before we dispense. And there are so many drug delivery technologies that I probably didn't even get the chance to touch upon, but the more we know, the better we understand and the best we can treat our patients. And that's everything. If you have any questions, you can write them in the chat, or you can say them out loud, or you can email me later, whatever you're comfortable with. Oh, okay. So, here we go. So why do some prescribers order fentanyl patches Q48 instead of Q72? That's a great question. From what I know is that they're typically used Q72. Honestly, I haven't seen very many Q48. I feel like I know that that happens though. I honestly would have to look into that because I'm not entirely sure. But I could definitely get back to you on that. I'm not sure on that one.
Dana?
Yes.
Some prescribers actually say that patients aren't well maintained with the pain, their level of pain every 72 hours, or they're faster metabolizers, so they like to change it every 48 hours.
Okay.
That's where some of them come from. Sorry to interject.
No, thank you for helping me. I didn't know about that. Anybody else? Okay. All right, so I don't see any more questions, but obviously feel free to email me, and then I will definitely be emailing all of you the post-assessment questions. so that you can get the credit for the CE. Let's see. Sure, thank you for coming, everyone. Thank you. Yay, thanks everyone.